So this video is about the complications of anterior dislocation of the shoulder. So when you divide the complications of anterior dislocation, there are mainly three complications comes under the structural complications. What are those complications? They are the Bankard's lesions, the Hill-Sachs lesions, as well as the slap lesion, superior labrum anterior to posterior. And today we are going to see about the Bankard's lesion only. So yesterday also I got a call from my students saying that the videos are too long, so I have to cut short my videos. So what is a Bankard's lesion? So Bankard lesion is actually a complication of anterior dislocation of the shoulder where there is an injury occurring to the glenoid labrum. Okay, and which part of the glenoid labrum is affected in Bankard's lesion? So, in case of Bankard's lesion, the injury is happening to the anterior as well as inferior aspect of the glenoid labrum. So, the injury is happening to the anterior as well as the inferior aspect of the glenoid labrum. Anterior inferior aspect of the glenoid labrum. So, I made a diagram for Bankard's lesion. This is my diagram, and I consider this diagram is the best diagram to remember. So Bankard's lesion is also known as 3 o'clock to 6 o'clock lesion. 3 o'clock to 6 o'clock lesion. Why it is called as 3 o'clock to 6 o'clock lesions? So imagine shoulder joint as a clock. So in the clock, the 12 o'clock is the superior aspect, and 6 o'clock is the inferior aspect, and 9 o'clock is the posterior aspect, and 3 o'clock is the anterior aspect. So in case of a Bankard's lesion, the injury is happening at the anterior inferior aspect of the glenoid labrum. So where this injury occurs, so the injury is occurring. Imagine it has a clock. The injury is happening between 3 o'clock and 6 o'clock in the clock. The injury is happening or occurring in the space between the 3 o'clock or the 6 o'clock area in the clock. Okay, so this red line is the injury happening during Bankard's lesion. That is the anterior inferior aspect of the glenoid labrum. So it is called as the 3 o'clock to 6 o'clock lesion. Some books they are saying that 3 o'clock to 7 o'clock lesion, but when you are taking a 7 o'clock, the position will come to the posterior aspect also. So there is no injury happening at the posterior inferior aspect. So 3 o'clock to 6 o'clock lesion is the more corrective form of injury. Okay, so that's about the Bankard's lesion injury. So Bankard's injury is actually a complication of anterior dislocation of the shoulder where the injury is happening to the anterior inferior aspect of the glenoid labrum. So what are the structures which are affected? Of course, due to this injury, the rotator cuff weakness can occur. And what are the ligaments that can be affected by Bankard's lesions? So the main ligament which is affected during Bankard's lesion is the inferior glenohumeral ligament, and especially the anterior band of the inferior glenohumeral ligament is affected during the Bankard's lesion. So in case of Bankard lesion, the main ligament which affected is the inferior glenohumeral ligament, and especially the anterior band of the inferior glenohumeral ligament is affected in case of Bankard's lesions. And what are the clinical features? Same like the anterior dislocation, the clinical features like pain, clicking sound, the patient will have the anterior apprehension test positive, the head of the humerus can be felt anterior. All those clinical features which what we had seen in the anterior dislocation is same for this Bankart lesion also. And when I look for any specialty test for Bankart lesions, I couldn't find any specialty test, especially to the Bankart lesion, but there are specialty tests for slap lesion. So when I look into the mechanism of injury and the type of injury occurring in case of Bankart lesion, and when I analyze the pathomechanism, biomechanical analysis of Bankart lesions, I formulated a test which is called as DK's hand to butt test. DK's hand to butt test. So what I try to do in this test is that I try to actively compresses the anterior inferior aspect of the glenoid labrum. Okay, I try to actively compress as well as provoke the anterior inferior aspect of the glenoid labrum, so that when you try to do this movement, the pain worsen. How will you do this movement? So ask the patient to bring his affected arm and touch the opposite inferior gluteal fold. You got it? Ask the patient to bring the affected hand and to touch his opposite inferior gluteal fold. Okay, so for example, if your left shoulder is suspected of a Bankart lesion, you ask the patient to bring his left hand and ask the patient to touch his right inferior gluteal fold using the dorsal aspect of his hand, using the dorsal aspect of his fingers. Ask the patient to touch the opposite inferior gluteal fold, opposite inferior gluteal fold. So why I am asking the patient to touch the inferior gluteal fold rather than keeping the hand at the back is that when you are keeping at the hand only at the back, you are not provoking or you are not providing a real compression force on the anterior inferior aspect. But when you are keeping the hand behind the back and try to and stretch and try to touch the opposite or the contralateral inferior gluteal fold, there is actually an active compression, actually as well as a provoking. It is actually provoking the anterior inferior aspect of the glenoid labrum. So you cannot see this particular test, hand to butt test, in any book or any of the videos. So this is formulated by me, and I am publishing this particular test. And if you are a university student, don't write the test. Okay, and if you are a clinical therapist, you can do this test and take it from me. This will provide very high sensitivity rate. Above 95% of sensitivity rate you can see in DK's hand to butt test. Okay, and in case of Bankart lesion, so when the patient is having the Bankart lesion, so what are the movement mainly you have to restrict, especially hand behind the back movement as well as the internal rotation, extreme range of internal rotation and the end range of extension as well as internal rotation need to be prevented, because this can cause further injury to the anterior inferior aspect of the glenoid labrum. So this is actually about the Bankart lesion. So Bankart lesion is actually an injury to the anterior inferior aspect of the glenoid labrum, which comes under the complications of anterior dislocation of the shoulder, and this is called as 3 o'clock to 6 o'clock lesion. Why it is called as 3 o'clock to 6 o'clock lesion is that you imagine a clock, and this diagram also you cannot see in any book or any of the videos. Most of the diagrams in the books and the videos are too complicating. So I formulated this diagram so which is so easy for you to remember. Just imagine this clock 12 o'clock is superior, 6 o'clock is inferior. And main two confusion is that 9 o'clock, make sure that it is posterior, and 3 o'clock is anterior. And imagine this red line between 3 and 6. So the injury is happening between the anterior inferior aspect of the glenoid labrum. Okay, so when you want to go for a particular test, this is my test, and this is called as hand to butt test. Since I named this as DK's hand to butt test, where you are asking the patient to bring his affected hand and ask the patient to touch the opposite inferior gluteal fold using the dorsal aspect of his hand. The patient complains of severe pain, or the pain worsens in doing this test. This is because this is actually an active compression as well as a provoking test for the anterior inferior aspect of the glenoid labrum. Okay, so, and when you are suspected of a Bankard's lesion, try to avoid any activities which will provoke or which can produce a compression force on the anterior inferior aspect of the glenoid labrum, especially the extreme range of internal rotation as well as the extension activities. Okay, and the main ligament which affected in Bankard's lesion is the inferior glenohumeral ligament, especially the anterior band of the inferior glenohumeral ligament is affected. Okay, so that's about the Bankard's lesions. Next, let us see about the Hill-Sachs lesions. What do you mean by the Hill-Sachs lesions? What is known as the Hill-Sachs lesion? Hill-Sachs lesion. So, Hill-Sachs lesion is when there is any anterior dislocations. When there is an anterior dislocation, so what is happening to the head of the humerus? The head of the humerus is moving anteriorly, inferiorly, as well as medially. The head of the humerus is moving anteriorly, inferiorly, and medially. So when the head of the humerus is moving anteriorly, inferiorly, and medially, what will happen to the head of the humerus? You can see the head of the humerus. You can see this is the posterior lateral aspect of the head of the humerus will make a contact with the anterior inferior rim of the glenoid fossa. Okay, so when there is an anterior dislocation, since the head of the humerus is moving anteriorly, inferiorly, and medially, imagine this position, and anteriorly, inferiorly, and medially, and what will be the final position of the head of the humerus? The head of the humerus posterior lateral aspect, the posterior lateral aspect of the head of the humerus will make a contact with the anterior inferior rim of the glenoid fossa, anterior inferior rim of the glenoid fossa, which can cause an indentation fracture at the posterior lateral aspect of the humeral head, which is called as the Hill-Sachs lesion. So Hill-Sachs lesion is nothing when there is an anterior dislocation. Since the head of the humerus is moving anteriorly, inferiorly, and medially, this will cause an indentation fracture at the posterior lateral aspect of the humerus, since it is making contact with the anterior inferior rim of the glenoid fossa. Okay, so what is the problem if there is an indentation fracture? So when there is an indentation fracture occurs, if it is left untreated, what happens? This can result in recurrent dislocation of the humerus. So whenever there is a slight abduction and external rotation, since there is an indentation occurs, this head will easily move out of the glenoid fossa. So in case of Hill-Sachs lesion, if it is left untreated, this can result in recurrent anterior dislocation of the shoulder. So surgical correction need to be done arthroscopic surgical correction. This can be done by using the soft tissue repair, or the bony correction need to be done in order to correct the heel sac lesions. Okay, so that's about the heel sac lesion. So I want to keep my video below 15 minutes. Okay, so our next video will be the slap lesions. Hope you guys understand, and keep in your mind about the 3 o'clock to 6 o'clock lesion, that is the Bankard's lesion, as well as the test DK's hand to butt test. Okay, hope you understand, and thank you so much. Bye bye.